So today we're going to talk about cardiac and pericardial masses. Get the microphone closer to you guys. I see you strategically moved it away there. So that's how you know he's the senior resident. Okay, so echocardiography showed an intracardiac mass. We have very smart CT scanners. They come out with arrows on the images to show you where the mass is. Right? Who said that? Yes, so that is the crista terminalis, a normal structure, not to be mistaken for a mass. So what is the crista terminalis?
Normal structure.
Yes? There's food today? Okay, so it's an embryo, what? It's an embryologic remnant. Like a vein or something. So it results from the incorporation of the SVC and the IVC into the right atrium during embryology. So that separates the smooth portion of the right atrium from the trabecular portion of the right atrium. It's actually a ridge of tissue that extends along that line from the SVC to the IVC. So that is the crista terminalis. It is not anything abnormal, so you don't want to mistake that for a tumor or a blood clot. Okay? So who wants to talk about this case?
Filling defect in the left atrial appendage.
Yes, so what could that be?
Thrombus, maybe patient has AFib.
Yeah, so the most common thing to give you a filling defect in the left atrial appendage is going to be thrombus. Of course, the most important underlying condition is atrial fibrillation. Also notice the left atrium is somewhat enlarged. This can also be associated with mitral valve disease. So the disease of the mitral valve, mitral stenosis, can also predispose to formation of thrombus in the left atrium, especially in the left atrial appendage. Okay? So it's most commonly in the left atrial appendage, enlarged left atrium, atrial fibrillation, mitral valve disease. All of these can be associated with thrombus formation. Here's a nice two-chamber view showing you the thrombus in the left atrial appendage. Remember that because of the narrow opening, there's a lot of stasis and blood flow in this region. So it's a very common location to develop clots in the left atrium. What do we think of this?
Pseudothrombus.
So first of all, the arrow is pointing to the anatomically, this represents what?
Left atrial.
Left atrial appendage. How do you know that that is pseudothrombus?
The line.
Yes. So there's a line here, right? So that's a clue that you may be dealing with pseudothrombus. So this is also associated with atrial fibrillation, slow flow within the left atrium. So you can have contrast here that is denser than the blood. So you have unoclassified blood that layers on top of the contrast. So how do you prove that that's pseudothrombus?
Delayed.
Yeah, so you get delayed images that allows mixing of contrast here, and then that will go away. Also, you can turn the patient prone. So if you turn the patient prone, then that also allows the contrast to fall into the tip of the left atrial appendage. So delayed CT, pretty easy to do here, and then that shows that it fills in completely, so that is pseudothrombus in the left atrial appendage. So thrombi in the right atrium, so these can be associated with any central venous catheters. So the thrombus can extend from the catheter into the right atrium. It can form at the tip of the catheter. This is an example with someone with a ventricular shunt here going into the SVC and right atrium. So thrombus formation at the tip of catheters that can extend into the right atrium. This is also not unusual. Okay? So here is a 30-year-old man. What are we looking at and what are the findings here?
2-view and 4-view SSFP.
Is there anybody else who's going to play? Or?
I'll shut up.
We have a 2-chamber right blood image SSFP on the left, on
Yes.
the right 4-chamber view.
Yes.
There's apical hypokinesis with filling defects.
Yeah, so or maybe even dyskinesis here in the apex of the left ventricle. Does that surprise you given the history?
No.
No? And you say there are filling defects, right? So what do you think those filling defects are?
Thrombi.
Thrombi. So is this a setup for thrombus? Somebody who's had an infarction and has
Yes.
a abnormal wall motion at the apex. How can you prove that these are thrombi?
Get delayed images.
What do you mean?
Delayed contrast images.
So, well, we can give contrast, right, and see what happens. So here's your MDE, myocardial delayed enhancement images. What does this demonstrate?
Delayed enhancement of the apex.
Does that surprise you?
No.
So what is that from?
Infarct.
And what distribution?
LAD.
How do you know that's an infarct and not anything else?
It's in that distribution and involved with endocardium.
Yeah, so it involves the endocardium, it's in the distribution of the LAD. What about these filling defects?
They don't enhance.
How do you know? This looks really bright to me. I mean, it's brighter than the blood pool. How do you know it's not enhancing?
We can confirm it with changing the TR.
All right, so again, we have,
Sorry.
so, nobody pays the point. So, how would you, so what would you do? What would you do to prove that it's thrombus then? What is the next step?
Increase the conversion recovery time to 600.
Yeah. So to differentiate tumor from thrombus on a 1.5 Tesla unit, what you can do is increase the inversion time to 600. And what happens with thrombus?
It gets darker.
Yeah, it gets darker, it suppresses. Now, another common appearance for thrombus, and this also you should think about, is you see that along the edge, you see how it's dark along the edge and brighter on the inside? This is also a typical appearance of thrombus when you're looking at your standard myocardial delayed enhancement views. But again, how do you know there's no enhancement on the inside of this lesion? Well, with thrombus, it can have high signal on T1 weighted images. That's why it can be bright. So what you would do is increase the inversion time to 600, and this suppresses the signal from thrombus. So the thrombus stays dark here. Okay, tumors would not suppress. Tumors that are enhancing would not suppress with a TI of 600. So this is what we do to differentiate thrombus from tumor, prolong the inversion time to 600. Okay. Here is a 46-year-old with heart failure. What does this show?
It was the left. Four-chamber view, there's like a left ventricular filling defect.
So on this 4-chamber view,
Oh, I take it back. Actually, on the 4-chamber view, I'm seeing the filling defect in the right ventricle.
yeah, so at the tip of the right ventricle, there's a filling defect.
Yeah.
Anything on this view?
I see a filling defect on that view of the left ventricle.
Yes, here there's a filling defect in the apex of the left ventricle. What do you think of the wall motion?
Just feels hypokinetic.
Diffusely hypokinetic, pretty dramatically hypokinetic. This shouldn't surprise you. It's a person with heart failure. So what do you think? What do you think this represents?
Just thrombus.
Yeah, again, this is thrombus. Patients with heart failure are also at increased risk for developing thrombus, and that can occur in either ventricle. So it can occur in both ventricles, the left ventricle or the right ventricle. And again, here's MDE with an inversion time of 600, showing you the thrombus nicely. Here it's along the wall of the left ventricle. Here it's at the apex of the right ventricle. There's the thrombus there, the right ventricle there. Okay, there too. So thrombus is the most common intracavitary mass. Usually homogeneous attenuation on CT, can have heterogeneous signal on MR, low signal on gradient echo images. There should be no enhancement with thrombus. And as you said, sometimes on your standard MDEs, that darkness, that dark rim can also be seen with thrombus, but it always helps to to confirm it with the prolonged inversion time images. So here there's calcification of the apex from a true aneurysm, and because of the abnormal wall motion, this is a common location also to develop thrombus. Chronic thrombus can also calcify, so you might also see calcification within chronic thrombus. So this patient is status post an ablation procedure for their AFib. What do we have here? Yeah, so here you see this mass behind the wall of the left atrium, right? But in this case, you see it's a very smooth walls here. The angles are obtuse, so this is actually outside of the atrium, it's in the wall of the atrium. So this is an intramural hematoma as a complication of the ablation procedure. So as a complication of the ablation, they kind of burn the endocardium around the ostia of the pulmonary veins, and then sometimes they can develop hematoma. So this is hematoma, but it's actually in the wall of the left atrium. All right, so who wants to discuss this case? What was that?
On the left, we have a black blood sequence 4-chamber view. On the right, we have a right blood sequence 4-chamber view. There's this right atrial mobile filling defect.
Correct? So what could that be?
Myxoma.
So what's the most common location for myxoma?
Atrial, but it can happen in the right atrium.
Yeah,
as well.
so myxomas most commonly occur in the left atrium, but the second most common location for myxoma is in the right atrium. Anything else in the differential?
Metastatic disease.
From what?
Um,
Well,
IVC extension from like HCC, RCC.
Okay.
you know.
So this could be extension of tumor, right, that's growing up the inferior vena cava into the right atrium. Also in the differential, of course, would be thrombus, right? But tumor also growing up into the right atrium has to be considered, and actually, that's actually more common than myxoma, okay? And so on additional images on this patient show what?
RCC.
Yeah, so there's a tumor here in the kidney, so that's an RCC, and it's invading into the inferior vena cava, growing up the IVC into the right atrium. Okay?
Dr. Mel,
Yeah.
I know like thrombus, like it doesn't enhance, but does tumor thrombus enhance?
Yeah, so tumor thrombus can enhance.
Okay.
So if you have pre and post images, you look for enhancement, and then that tells you that it's tumor thrombus as opposed to gland thrombus, that it contains tumor in it. All right? So this should be familiar to everybody who's done CT here. What do we got here?
HCC extension into the right atrium.
Yeah, so again, we have a filling defect into the right atrium, but in this case, there's a tumor in the liver that's actually growing into, here's the portal vein, and then here it's actually growing into through the hepatic vein into the IVC, growing up the IVC into the right atrium. So tumors that can grow through the IVC into the right atrium, renal cell is the most common, but hepatocellular carcinoma can also do it. What other tumors can do this?
Adrenal.
Yeah, adrenal tumor, there's one other tumor also.
The ovarian?
Yeah, ovarian tumor, right, ovarian tumor can also do it. But the most common, of course, is renal cell, and the second most common would probably be HCC. What's going on in this case?
We have a lung mass with extension into the pulmonary vein into the left atrium.
Yeah, so in this case, there's a filling defect here in the left atrium, but what you also see is a nodule out here peripherally, and then here there's a lung mass. So lung masses can invade into the left atrium, so if you have a mass in the left atrium, one thing to consider, again, and this they might see the mass with echocardiography, they're not going to see the lung mass. But lung mass can invade into the left atrium by growing through or around the pulmonary vein. So this is lung cancer invading into the left atrium by growing through the pulmonary vein. Okay? Metastatic lesion is the most common cardiac neoplasm. Would be a metastatic lesion, right? The sites of tumors, the primary tumors that can, what are the most common tumors that metastasize to the heart and pericardium?
Lung and breast.
Lung and breast, right, just kind of statistically, but any tumor can do it. Melanoma is always a good answer for tumor metastases to an unusual location. Right? So solid mass, this one's infiltrating the myocardium, enhancement. Most common thing when you're dealing with neoplastic involvement or neoplasm is going to be metastatic disease. That's always the first thing to think of. So these secondary neoplasms, 40 times more common than primary neoplasms. lung cancers by mediastinal, and mediastinal tumors by direct extension, renal, adrenal, liver via the IVC, and of course metastatic disease. So whenever you're dealing with what looks like a cardiac neoplasm, always think metastatic disease first, because that's far more common than primary cardiac neoplasms. Okay? So this person presents with a hemorrhagic lesion in the brain. See that there? CT of the chest was done to look for underlying primary neoplasm. Those are our images from our chest CT. So who wants to discuss this? What do we have there? Do you see anything on the chest CT images?
There's this soft tissue density that appears adherent to the interatrial septum in the left atrium.
Yeah, so here, there is this area here, right? So might make you think of something. So what will we think about here?
Myxoma, papillary fibroelastoma.
Well, does papillary fibroelastoma attach itself to the interatrial septum?
No.
No. Do they tend thrombus? Also, you might think about thrombus, right? Although it's interesting, when you mention thrombus that's attached to the interatrial septum, there's a nice story you can put together for that. A thrombus in the left atrium attached to the interatrial septum. What's the story you would put together for that? How do you get a thrombus in the left atrium attached to the interatrial septum?
ASD kit.
Yeah. So if they have a pain foramen ovale and they're having what? What other part?
DVT.
Which gives you? What does the DVT give you?
Paradoxical embolism.
Pulmonary embolism. So if somebody's actively having pulmonary embolism and they have a pain foramen ovale, right, the clot can actually go across and get stuck within the intraatrial septum, right? So that also is a possibility, something to think of. You mentioned left atrial myxoma, right? So certainly. So what might we do to evaluate this further? MR, right. So what view would you like? Four chamber. Yeah, four chamber SSFP. Now imagine in your head what you're about to see on the MR. Why would you see that? Okay. So imagine what you would expect to see on MR. There's the MR.
I just think turbulent flow at the mitral valve.
Yeah, you see some turbulent flow at the mitral valve. Where's the tumor?
Dislodged.
So the tumor dislodged. The whole tumor is gone,
That's
right?
it, yeah.
That's it. That's your answer. You're sticking with it. Any other possibility?
This is not the right sequence for it.
Why not?
It's like matching the,
So is it possible that the signal intensity of the tumor matches the signal intensity of the blood pool? So what would you do?
Spoiled SPGR.
So you can try that, yeah, certainly. So remember, these are non-spoiled, so this is steady state free precession. So we talked about if you're looking for, especially if you're evaluating turbulent flow, if you're looking for valvular lesions, that there is another sequence that we can do, a non-balanced gradient echo. G calls it fast Sine, it's a spoiled grass kind of sequence. There's the tumor, right? Now, a few reasons why the tumor shows up better. First, the signal characteristics are different. So for SSFP, the signal characteristics depend on what? For SSFP, what determines the signal characteristics? The T2 to T1 ratio. The T2 to T1, the ratio of the T2 to T1 times determine the signal characteristics on SSFP. So here, you could see it better. Also, what tends to happen for the same reason that you can see abnormalities of the valves is that turbulent flow around the tumor will show up as darker areas, okay? So if you're having trouble seeing a tumor on SSFP images, you might want to try a spoiled grass, cardiac gated spoiled grass sequences to show you the lesion. And there it is. And then of course, here we have dark blood imaging, pretty easy to see here on the dark blood images. What are the characteristics of this that tell you it's a myxoma?
Mobile.
It's mobile, so it extends through the mitral valve. So it prolapses through the mitral valve. And the first thing you already mentioned, it's attached to the interatrial septum. So those two characteristics, attachment to the interatrial septum and a mobile mass that prolapses through the mitral valve, if you see that, then the first thing to mention is left atrial myxoma. Okay, there'll also be some enhancement after we give gadolinium in these tumors. And this we've already discussed. The typical features that help you to identify the tumor, two important things. One, it prolapses through the mitral valve. Two, it's attached to the interatrial septum. So if you have those two things, you start with myxoma on your differential diagnosis. Okay? So these are mesenchymal tumors, often pedunculated, and these are very friable. Pieces of it break off very easily. That's why these patients can present with systemic emboli, with symptoms of systemic emboli as pieces of this tumor break off. The most common location is the left atrium. Second most common location is the right atrium. So they can cause obstructive symptoms if they're large enough from obstruction of the mitral valve. So they can mimic mitral stenosis. Most are solitary tumors. A small percent are associated with coronary complex. So here, in addition to myxoma, spotty skin pigmentation, and endocrine overactivity, the important thing of this is that the myxomas tend to be multicentric with a high recurrence rate. Usually just excision of it is curative when they're sporadic and solitary. Mass in the left atrium. You can have murmurs and symptoms that change with change in position, intermittent pulmonary edema from obstruction of the mitral valve, and clinically it can mimic mitral stenosis, systemic emboli, and pieces of the tumor break off. Okay. The chest radiograph sometimes can mimic mitral valve disease, so enlargement of the left atrial appendage, some pulmonary venous congestion. 99% of the time you see a chest X-ray like this, it's rheumatic heart disease causing mitral stenosis. The other 1%, it might be left atrial myxoma. So that is the differential for a chest radiograph that looks like mitral valve disease, mitral stenosis. Can drop out in signal sometimes on gradient echo images, can be lower in signal because of the iron content within the tumor. And here's a large one. In this case, it's actually obstructing the pulmonary veins because it's so large. And it can have some calcifications too, sometimes. So here, we have a tumor in the right atrium. Remember, we talked about right atrial tumors. The first thing we think about is tumor growing up the IVC, right? If you actually have a tumor inside the right atrium like this. But we can also have right atrial myxomas. That was the case here. These can also attach to the interatrial septum. These can also prolapse through the valve, through the tricuspid valve. Okay? It can mimic tricuspid stenosis from obstruction. You can have right to left shunting if you have a patent foraminal valley. So it can cause right to left shunting across the patent foraminal valley, and of course paraganglioma emboli. So right atrial myxomas can also occur. All right, what do we have here? Anybody see the finding?
There's a filling defect on the aortic valve.
Yeah, so there's a filling defect in the vicinity of the aortic valve. So what's the differential for that? What could that be? Actually, you see, look carefully, you can see it's actually attached. See that little, stalk coming off here?
First two things you think is vegetation and thrombus.
Yeah, so vegetation or thrombus, right? Absolutely, you have to think of that. And then the third thing is papillary fibroblastoma, right? So those are tumors that can be attached to the valve. So the aortic valve, more common than the pulmonic valve. Actually, the left-sided valves, aortic valve, mitral valve, more common than the right-sided valves. But a small tumor like that, these are usually asymptomatic, usually picked up incidental findings on echocardiography. Occasionally, they might be associated with emboli, formation of small clots on the tumor, but usually they're asymptomatic. So it's papillary fibroblastoma, a small tumor that is growing on the valve. Okay. So Second most common primary benign cardiac neoplasm, the most common one, of course, is myxoma. 75% of valvular tumors, usually small, solitary, can be found on the aortic or mitral valve, usually no associated valvular dysfunction. So papillary fibroadenoma. Most are asymptomatic, usually incidental finding. Cardiac tumor in a newborn. What do we think?
Rhabdomyoma.
Rhabdomyoma, yeah. So those tend to be the cardiac tumors in newborns, and that's associated with tuberous sclerosis. The natural history? What's the natural history of a newborn with rhabdomyoma, cardiac rhabdomyoma? Do they take them out?
No, they regress.
They regress, right. That's actually the natural history. Yes. So rhabdomyomas, these are really hamartomas that occur within the heart. So in signal intensity, they tend to be very close to the myocardium. 50% of tuberous sclerosis, and they can be multiple intramural ones, makes up 90% of cardiac tumors in infants and children, usually less than 1 year of age. In children, they tend to regress spontaneously. So rhabdomyomas. Thickening of the myocardial wall, usually an intramural lesion. Isointense to myocardium can be slightly hyperintense on T2-weighted imaging. These are two different patients with the same disease, characterized by seizures, mental retardation, and skin lesions. So what's the disease? Okay, what's the finding?
On the right, there's a lesion in the interventricular septum, and then on the left, right apical and right apical.
And what do these lesions have in common?
They're fatty.
Yeah, so they have fatty attenuation. So what do these represent?
Hamartomas.
Yeah, these are hamartomas. And so this is also associated with tuberous sclerosis, these hamartomas that can occur within the heart that in adults can have fatty attenuation associated with them. All right? So in this particular study where they looked at 55 patients, 64% had these foci within the myocardium. So this is associated with tuberous sclerosis. What do we have here?
Filling defect in the left hand.
So is that in the ventricle or is that in the wall?
Myometrial wall with calcium.
Myometrial. Myocardium.
Wrong one.
Okay,
Calcification.
and it has calcification, yes. So we have a mass here within the wall of the left ventricle. This one is associated with calcification. Any thoughts?
Yeah, MR.
All right, so you want an MR. Okay. There it is. T2-weighted MR, SSFP, post-contrast. What happens after contrast?
Enhances.
Yeah, marked enhancement. Remember we talked about metastatic lesions is always the first thing that you think about, right? But what else could this be and what's the clue?
T2 weighted images.
What about the T2-weighted?
Dark.
It's
So
dark
like-
on T2, so what does that tell you?
Mets or something would be brighter, so in this case, Fibroma.
Fibroma, right. So just like in the myometrium,
Yes.
right? Where you can have leiomyomas that tend to be dark on T2-weighted imaging because of a high fibrous content, okay? If there's a high fibrous content, and most neoplasms are bright on T2, but if there's a high fibrous content, they can be dark on T2. These also enhance, these tend to enhance. So this is fibroma. These are also associated with calcifications, like you see here. So a tumor within the myocardium with calcifications, dark on T2, so that is a fibroma, hypointense in this case on T1 and T2. Right? So this is a fibroma. They can affect children. They can be congenital. Second most common cardiac neoplasm in children. Most common to be resected because rhabdomyomas regress. It is associated with Gorlin syndrome, and they can be symptomatic if they're large enough. Can result in arrhythmia, sometimes with some death because of interfering with the conduction system. So those are fibromas. So they can be calcified. 25% have calcifications. Okay? And dark on T2. And they enhance with contrast. Okay, so here we have T1 and T2-weighted imaging. What do we have? What are the characteristics there?
Very bright T2.
Yeah, it's very bright on your T2 weighted images, right? So you have this lesion here that is very bright on T2, right? And here's our initial CT, here's a 5-minute delayed CT, and here is a PET scan.
There's nothing worrisome because the PET scan is not really.
Okay, so first of all, you don't have much metabolic activity within this, so it doesn't seem to be an aggressive lesion, right? So it was bright on T2, and what else can we say about the CT imaging here? What happens to the tumor on the delayed images?
Matches the.
Yeah, it disappears, and the reason it disappears is because it's become iso-intense, iso-attenuating to the blood pool, right? So what does that? Hemangioma, right? So this is a cardiac hemangioma. So just like in the liver, you can have hemangiomas that can occur in the heart. They will be very, very bright on T2 weighted imaging, and you can see the characteristics of contrast here, and also not much activity on your PET scan. So that is a hemangioma, very bright on T2. Can be intermediate on T1. Right? Benign tumor, sometimes they might have, of course, calcifications within these tumors too. Hemangioma. 64-year-old with a mass in the right atrium with echocardiography. Is that a crista terminalis?
No.
No. So here's T1 weighted imaging. Too lobulated, too big to be crista terminalis. What else can you say about it?
Right on.
Yeah, it's very bright on T1 weighted imaging. So what are you thinking about here?
Matches the signal that I see with fat. So I think it might be fat, like lymphoma,
So what would you do to prove that?
fat saturated
Okay,
sequences.
so you'd want to do imaging with sequences that would show the fatty nature of the tumor. And so here's your fat saturation image, and you can see that the signal drops out. So this is a lipoma. So lipomas can occur within the heart. They can occur typically near the location of the intravenous cava along the right atrium, but they can occur anywhere in the heart. You can have cardiac lipomas. And the signal characteristics of fat would tell you that you're dealing with a lipoma. Easy on CT, right? We can tell that that's pretty easy. That's fatty attenuation there on CT. So that's a cardiac lipoma, right? Near the atrial septum, smooth tumor, fatty attenuation, and of course, with fat saturation, you can show that it contains fat. Another one, this one is big, right? Very bright on T1. It really drops out its signal there, and fatty attenuation here, also on CT. Now these tend to be very soft and pliable, which is why they'll change shape. You see how it's kind of changing shape throughout the cardiac cycle? Because these are very soft tumors. Lipomas are very soft tumors. This patient has hypertension. And we see a mass, right? So any thoughts on this? Okay, so if it were an adrenal, you'd call it a pheochromocytoma. Outside of the adrenal, we call it paraganglioma. The signal characteristics of paraganglioma, what does that do on T2 weighted imaging? No, not on T2. That's another lesion that's very bright on T2 weighted imaging, right? These are vascular tumors. So here you can see the cardiac cath, very vascular tumor. So they also enhance very nicely with contrast because they're vascular tumors and bright on T2. So paragangliomas, many times they produce catecholamine like pheochromocytomas. 20% might have paragangliomas elsewhere also. Most commonly from the roof of the left atrium of these tumors, these paragangliomas. So tumors like that, kind of near the top of the heart, They're avidly enhancing when you give contrast. And they tend to be bright on T2 weighted imaging. And if you're looking at, you can look for them, of course, with MIBG. You look for activity within the paraganglioma tumor. This patient has an arrhythmia, or has arrhythmia. And here are the findings on the CT. What kind of image is this? What plane is this? Well, if I'm showing you cardiac cases, they're limited in terms of, yeah, that's a short axis view, right, post contrast. So this guy is what?
That's the left ventricle.
No,
Left atrium.
that's the left atrium, and this is
Right atrium.
right atrium. Yeah, just like you can get short axis views through the ventricle, you can also get short axis views through the atria. Right, so it's a short axis view through the atrium. So what's the finding?
Thickening of the interatrial septum.
Yeah,
Low attenuation, almost fatty.
almost fatty or is fat?
Fatty.
Yeah. So what is this?
Lipomatous interatrial hypertrophy.
Yeah, so lipomatous hypertrophy of the intratracheal septum. In most cases, this is asymptomatic. Why does the patient have arrhythmia?
SA node.
Yeah, the SA node lives here, right? So in some cases, it can be infiltrated with this lipomatous hypertrophy of the intratracheal septum. Right? So thickening of the intratracheal septum, classically it's said to have a dumbbell appearance like this. You see where it drops out where? Yeah, the fossa ovalis, right? So that's lipomatous hypertrophy of the intratracheal septum. It is brown fat associated with aging and obesity, can be associated with arrhythmia because the SA node lives there. Fatty thickening of the intratracheal septum if it's more than 2 centimeters, the criteria for diagnosis. Okay? There's a nice dumbbell shape, drops out there, the fossa ovalis. And you can show it's fat with fat saturation. If you see when it drop out, of course, you can see it's fat when you look at the CT. And this patient has gastric cancer and has this finding on their PET CT scan. Is this a metastatic lesion? No. So again, we're dealing with lipomatous hypertrophy of the intratracheal septum, but you have to remember that this can give you false positive findings on PET scan because brown fat, right, contains brown fat. So it can be metabolically active when you do PET scan. So it's important to look at the CT when you have activity there to see if that is the intratracheal lipomatous hypertrophy of the intratracheal septum. Right? So that can have increased activity on PET scan. Now remember that, so do you think this is benign or malignant? What makes you think it's malignant?
Looks like
It just, what is it about it that looks malignant?
infiltrated.
Yeah, so it's infiltrative, okay, so it involves the pericardium here. It's kind of spanning, affecting more than one chamber. So it has a very infiltrative appearance to it. Looks like it might also be invading the cardiac chambers itself. So we think this is malignant. Of course, when you think you're dealing with a malignant cardiac tumor, the first thing you say is
That's
Mets, right. Mets is always the first thing that you say. But in this case, I'm asking you, what primary cardiac tumor would this be? So angiosarcoma. So why do you say angiosarcoma?
infiltrated looking bad tumor in the right atrium.
Yeah, so it's a right-sided tumor. The most common primary malignant cardiac tumor is angiosarcoma, and they tend to be right-sided. Right? So it's a right-sided malignant appearing, and we've told you it's a primary cardiac tumor. So angiosarcoma is what you would go with here. So malignant-looking tumor, right-sided, like that. So of the sarcomas, there are different ones, but angiosarcoma is the most common, so you always see angiosarcoma first, especially if it's a right-sided tumor. Tumor involving more than one chamber, wide port of attachment, hemorrhagic pericardial effusion, cavitary, intracavitary involvement, if it extends to the pericardium, pulmonary veins, pulmonary artery, or mediastinum, and of course if there's metastases. So kind of obvious from looking at the lesion that it looks like a malignant tumor. So these angiosarcomas, most commonly right-sided. Other sarcomas are more commonly left-sided. The angiosarcomas have a striking right-sided predominance. Most have Mets at presentation. And as we've said, the other sarcomas tend to affect the left-sided chambers. So it might also involve the valves occasionally, these types of tumors. So angiosarcoma, big, ugly, right-sided cardiac tumor. Primary cardiac tumor, angiosarcoma. Other sarcomas, like here's a leiomyosarcoma, they tend to affect left-sided chambers. This is leiomyosarcoma on the left side. Here's a very strange looking tumor. So if I tell you this is a primary cardiac tumor, what tumor might this be? That looks like, osteosarc. It's rare, but these can also occur in the heart. So the bone-forming tumor here, this was an osteosarcoma. So the history is very important here, right? Tell you the patient's HIV positive. Does this look malignant or benign? Malignant. So what would you think of here? Lymphoma is the answer, yeah. So HIV positive patients have an increased risk for lymphoma. So if they have a cardiac tumor, here you would think lymphoma. These are infiltrative tumors, very ugly looking, and these are also associated, here you have a pericardial effusion associated with this tumor. So lymphoma, cardiac lymphomas, involves the heart of pericardium, and it can be limited to the heart. No evidence of extracardiac lymphoma. Rare tumor, usually non-Hodgkin's lymphoma, and it is associated with AIDS.
Dr. Mohammed, and
Yeah.
wait, that tumor had sort of like cystic components, no?
Yeah.
And
This
that's
one,
common for cardiac lymphoma?
well, the larger the tumor gets, the more heterogeneous they can appear.
Okay.
Okay. But in a patient who's HIV positive, it looks like they have a cardiac tumor. Lymphoma is always a good bet, always a good place to
Not
start.
just necrosis?
Yeah, could be, necrosis. Also, if the patient's been treated, right? If the patient has received any treatment, you can also get necrosis of the tumor. So cardiac lymphoma, heterogeneous, right atrium, right ventricle. These also tend to be right-sided. So angiosarcoma might also be in your differential. Again, we always start with metastatic disease, right? Metastatic disease, angiosarcoma, lymphoma. So lymphomas and angiosarcs tend to be right-sided tumors. So benign tumors, myxoma, papillary fibrillary, we've talked about these. We've discussed the malignant tumors also. The finding on the chest radiograph. What's the finding on the chest radiograph?
There's a well-rounded opacity obscuring the right heart border,
So the location of this opacity is?
right pericardium.
This on the chest x-ray, what do we call this region? The cardiophrenic angle, right? So what's the differential for a mass in the cardiophrenic angle? Differential of mass in the cardiophrenic angle. What's the differential?
Epicardial fat pad.
So fat pad, right? What else?
Cyst.
Pericardial cyst, what else? Can you have diaphragmatic hernia there? Yeah, Morgagni hernia, yes. And can you have lymphadenopathy there?
Yeah.
So what story do you get lymphadenopathy in the cardiophrenic angle?
That's from like a primary lung, like.
Well, lung doesn't tend to go to the cardiophrenic angle. Recurrent lymphoma can give you enlargement of nodes in the cardiophrenic angle, right? Also, with HCC, it's common to have lymph nodes in the cardiophrenic angle. Usually not large enough to see on the plain field. But remember, whenever you're reading the CT scan on those patients with hepatocellular carcinoma, you see a lot of nodes there in the right cardiophrenic angle, right? So liver tumors, hepatocellular carcinoma can also give you lymphadenopathy at the cardiophrenic angle. Okay. So the answer here is pericardial cyst. So these are usually a fluid attenuation. They usually do not communicate with the pericardium. They can be in the right or the left cardiophrenic angle. So, moving on to pericardial tumors, pericardial cysts, secondary neoplasms, and then some other more unusual pericardial tumors. So these pericardial cysts don't communicate with the pericardial sac. Right or left cardiophrenic angle, right greater than left. Very smooth walled, and usually of fluid attenuation. Very bright on T2 weighted imaging, no enhancement when you give contrast. Might be slightly higher than fluid on T1 weighted imaging from proteinaceous contents. Of course, secondary neoplasms, always more common than primary neoplasms in case of breast cancer with mets to the pericardium, lung, breast, melanoma. Those are tumors that can metastasize to the pericardium. Teratomas are tumors that can occur in infants and children that can affect the pericardium. So a child with a pericardial tumor that could be a teratoma might contain calcification, might have a tooth within it. So teratomas can occur. Of course, you always think metastatic disease first, but if I tell you this is a primary tumor, what tumor could this be? Mesothelioma, right. Also, I guess in your differential, you might include lymphoma in your differential too, but mesothelioma, because of the pericardial effusion, all these soft tissue masses involving the pericardium. So mesothelioma is a primary tumor of the pericardium. So they arise from mesothelial cells. We know that mesotheliomas in the chest wall of the pleura associated with asbestos, not so clear about pericardial mesotheliomas, but ugly looking tumor with pericardial effusion. So that could be pericardial mesothelioma. Okay? So what do we need to remember? Crista terminalis, normal finding in the right atrium. You don't want to mistake that for a tumor. Always think thrombus first if you have an intracavitary mass, more common than anything else. When you're dealing with tumors, secondary neoplasms, metastatic disease, always more common than primary tumors and primary cardiac tumors. So that's usually your order of thinking. Thrombus is the most common intracavitary mass. Inversion time of 600 is a nice way to differentiate thrombus from tumor. The thrombus will suppress at the prolonged inversion time. Secondary neoplasms, much more common than primary. So mass in the left atrium could be lung cancer invading the pulmonary vein. Mass in the right atrium could be tumor growing up the inferior vena cava. For myxoma, if we see a mass attached to the interatrial septum prolapsing through the mitral valve, then your first thought would be myxoma for a tumor like that attached to the fossa valves. And the left atrium is the most common site. Can mimic mitral stenosis. Carney complex is the trivia question for association with myxomas. Lipomatous hypertrophy of the interatrial septum, fat in the interatrial septum. You want to remember that it can give you a false positive PET scan because of brown fat. Capillary fibroblastoma, small tumor, usually on the aortic valve, can also affect the mitral valve. Fibroma, dark on T2, it does enhance, but the dark on T2 might also have calcification for fibromas of the one. Sarcoma, angiosarcoma is the most common, malignant right-sided tumor. Angiosarcoma, you always think Mets first, but as a primary cardiac tumor, angiosarcoma. And pericardial cysts, very common. You will come across these quite a bit. So right or left cardiophrenic angle, usually fluid attenuation, in contact with the pericardium, but does not communicate with the pericardial space. Okay? Any questions? All right, very good.